0 to 800 when you're
imaging cardiologist currently based out of Nevada. Do I have that right?
You bet. Yeah. I live up here in Northern Nevada. I guess my state's not represented. I'm from Vermont. So that state's not here either. I don't know anybody. So that's my disclosure, but I'm collectively so proud of all of you guys coming in here on a Saturday. So have a great time. I look forward to this. You guys are awesome.
Great. Nikechi Yoma is our Jeopardy extraordinaire ringmaster, and she's been helping with or organizing Jeopardy at the ACC here for quite a few years now. She did her interventional cardiology fellowship at Mayo and is currently based out in the Mayo system. Nikechi, did you want to say something too?
Well, thank you to all the fellows. I know it's really hard in time of COVID to make out time to do this. So the college appreciates your willingness to be a part of the college actively, and we really hope that this has some value to you in terms of member engagement. Thank you so much for coming here this afternoon.
Yeah, and next up we have Brian Clark, who has been our buzzer controller extraordinaire for the whole morning today. I think he was up very, very early and has been on this is what, your 4th or 5th hour at this point. Okay. He's based out at Rush, right, in Chicago?
Yep.
And are you an electrophysiologist as well, or?
No, I'm general cardiology.
General cardiology.
Yeah.
Did you want to say something?
I don't know anybody that's participating here, so there won't be any buzzer bias.
Okay, yeah. All right. That's great. And you know what? Let's also quickly go around and have all the competitors just say maybe one line about yourself, something interesting, and what you're going into, just out of curiosity. So I'll start with the Arizona Mayo team, number 1. I see Katie Murphy out there.
Yeah, I'm Katie Murphy at Arizona. I'm going into heart failure.
Okay, great. Something interesting, Katie.
Something interesting about me?
Yeah.
Myself and Dr. Lee went to the same med school.
Oh, yes, you did. Bias.
Oh dear.
Okay, next.
I'm Senthil. I'm one of the 3rd-year cardiology fellows. I'm going to be staying here as a heart failure fellow. Something interesting about me at the moment, we just had baby girl number 2 about 10 days ago.
That's fantastic, Senthil. Yeah, I had my 2nd child at Mayo as well when I was fellow.
Hi, I'm Hassan Ashraf. I'm also a 3rd-year cardiology fellow at Mayo. I'm going into EP. Something interesting about me, I'm a big history buff.
Oh, that's great. Yeah, fantastic. Yeah, these are great times to be recording history. Okay, let's move on to Arizona number 2. Arizona banner number 2. You guys are very small, very tiny. But
yeah, unfortunately, we're trying to figure out how to work the camera in this room. So
okay,
sorry.
Well, let's go around the table and introduce yourselves and say something interesting.
Yeah, so my name is Aaron Whip. I'm a 3rd-year fellow here, going into general cardiology. Something interesting about myself, I have a 3-year-old, now 4-year-old daughter, and I'm running my first half marathon in a couple months.
Wow, fantastic. Wow, you trained in COVID. That's awesome. Next up.
Hi, my name is Christina Pecci. I'm also a 3rd year going into general cardiology. Something interesting about me is I used to do amateur boxing.
Wow.
And like world tournaments. Yeah.
Oh, all right, that is interesting.
My name is Myra Patel. I'm also a 3rd-year fellow. I'm going to also be going into general cardiology. And something interesting about me is I recently got into chess.
Chess? Oh, after watching Queen's Gambit like the rest of the world. All right, the Tucson crew.
Hi, I'm Chase. I'm one of the 3rd-year fellows going into heart failure. I guess something interesting is I just had my first kid 3 months ago. So
yeah. COVID babies, yay!
Exactly.
I'm Julia. I'm a 2nd-year fellow. I'm doing an interventional fellowship with my home program. Interesting facts about me. I like knitting.
You like knitting? Okay,
yeah.
Good. That's a great COVID
and I have 2
pastime.
cats.
I'm David. I'm a 3rd-year fellow going into general cardiology. I've got 2 kids and I went shopping for my first minivan this morning.
Oh, I remember that one. Yeah. Yes. You'll remember that car for many years. New Mexico, yeah, beautiful state. I was just there last week.
Yeah, so my name's Eddie Brown. I'm a third-year fellow. I'm gonna go into general cardiology. Something interesting about me is I really enjoy playing golf.
Oh yeah, yeah. This is yeah, golf is good in New Mexico. You should be going to interventional cardiology, by the way.
General. No one wants to be on call.
Yeah.
Like that.
Next up.
My name is Bharat. I'm a third-year cardiology fellow as well. Staying in general cardiology as well. Something interesting. I used to be a volleyball player for my state back home.
Wow, cool.
I'm Dan. I'm a third-year fellow as well. I'm going into EP. Something interesting with me, like a lot of other people here, I'm having a child soon, so in May.
Great, congratulations. Yeah, OHSU, team number 5.
Hey guys, I'm Ra, one of the second-year fellows here at OHSU, probably going into electrophysiology. I roast my own coffee, I guess, in kind of traditional.
Oh, wow, I want to be your friend. Yeah, I'm coming to Portland.
Hey, I'm Bobby Kerr. I'm second-year fellow. Probably going to EP too. Fun fact about me, I lived in 18 countries. I visited 18 countries, lived in 4 countries with separate.
Wow. Yeah, international man of mystery. Disappeared.
And then Tim was here. He's right here.
All right, well.
Tim.
Hey guys,
Tim.
second-year fellow going to interventional. Something interesting?
Yeah.
Ooh.
You must be interesting in some way.
Be a professional snowboarder.
Oh, wow, that is very cool. That is very cool.
And now I'm retired.
Utah.
I'm retired.
Utah number, oh no, sorry, Oregon blend. Sorry, I missed Oregon. Oregon, the sequence. Hello, Oregon blend. So that's like a fine wine.
It is like a fine wine. I'm Miranda. I'm a second-year cardiology fellow, probably going into EP as well, like everyone at OHSU apparently. And something unique about me is I really like Broadway musicals.
Wow, yeah, okay, cool.
I'm Saket. I am the current EP fellow, and the reason that you guys want to do EP.
True.
Something interesting about me, I played national level table tennis in India.
Oh wow, like Forrest Gump. All right.
I'm Sandeep. I'm a first-year fellow, and I guess the interesting thing about me is I'm meeting my teammates for the first time today.
Oh, wow. that is interesting. Hello, strangers. Utah. Let me get started. We have 1 minute.
First-year fellow. Something interesting about me, I used to live in Argentina.
Oh, okay, cool. Yeah.
And I'm Daniel, a second-year fellow, looking into going into EP. Something interesting about me and Bobby and Miranda on one of the Oregon teams, we all did residency together in Colorado.
Yep. Is there another person? Oh yeah, there you are. You've been hiding out in the corner of the camera.
Bobby, I'm a second-year fellow. I'll be doing interventional. And I guess something interesting about me is I've done 3 Ironmans.
Wow, that's pretty cool. So yeah, it's great to meet everybody. Thank you, as Nkechi pointed out, thank you so much for your interest and for your participation. This is tough. It's tough in person and it's harder at Zoom. But hopefully we're here to have fun today and learn something at the same time. I like the fact that some of the teams have this is just practice rounds for them for moving on. For the rest of you, I suppose it will be this will be competitive. But hopefully, once again, we're going to learn something together and have fun. So I'm going to try and share my screen for the forum. All right. Can you hear the music?
Barely.
Not really.
Barely?
Very soft.
That was nice.
Okay. I don't know how to make it louder, so we'll just say it's irrelevant, all right? All right, let's get started today. Nkechi, how do we decide who gets to go first?
Oh, we always start with that first question on the left-hand corner. So you can go ahead with genetics 100.
Okay, right. So
and you want to tell the audience where the team numbers are so they can follow the scores?
Yes, absolutely. Okay, so for the scores, this will be team 1, 2, 3. So number 1, this is Mayo, Arizona, you're Mayo green. BUMC Phoenix, you're red. Okay, that's red. Tucson is blue, Wildcats blue. New Mexico will be a nice maroon color. OHSU non-blend, your yellow gradient. And then the blended people are truly blended, you know, orange to black. And then Utah is light blue in the bottom. All right.
Oh, the decimal zone.
Okay, are we ready? All right, we're going to start with genetics 100. And the question for the genetics 100 is, Marfan syndrome is a connective tissue disorder inherited in an autosomal dominant fashion, with 90% of cases caused by mutations in this gene.
Team 4.
Fibrillin 1.
What is fibrillin 1?
Sorry.
What is fibrillin 1? Excellent. Well done. Team 4, green up here. We'll go. Okay, so that's fibrillin 1 extracellular matrix protein, FBN1. And early on, you know, obviously we would love for you to answer in the form of an answer like Jeopardy, but you know, we're not going to hold too tightly to that just because of this strange format and the thing. But if you can, try your best to answer in the form of a question. All right, so team 4, you have the board.
We'll do genetics for 200.
Genetics for 200. Okay, familial hypertrophic cardiomyopathy is a relatively common genetic disorder which shows this mode of inheritance, and be specific. This is too easy to not be specific.
Team 7.
Team 7. Utah?
What is autosomal dominant?
Yes, that is correct. Well done, Utah. What is autosomal dominant mode of inheritance? I don't know how you can be less specific than that. It's hard to know. All right. Team 7, you have the board.
Watch it.
Team 7, I can't hear.
Name that shunt for 200.
Name that shunt for 200. Okay. Team 7. All right, the specific name given to a descending aorta to left pulmonary artery anastomosis, and that is distinct. There are two, one to right. So,
Team 2.
That's BUMC Phoenix, Team 2.
What is scimitar syndrome?
No, that is incorrect.
Yeah.
Well, who was next team?
Team 1.
Oh, let me press the button first. Okay.
Team 1 was next.
Team 1. All right. Team 1 is Mayo, Arizona.
What is the POTS shunt?
Yes, that is correct. Team 1. Okay. What is the POTS shunt? So this is a descending aorta to left pulmonary artery. And you know, this is a favorite of Jeopardy because it lends itself well to Jeopardy. But I wanted to point out as well that all of the questions that have been written for the Jeopardy, and thank you for all the volunteers who have done this, they've all been based out of the ABIM blueprint. You know, we've been in the past quite enthusiastic about writing real Jeopardy questions, very, you know, obscure stuff, but everything that you see today is ABIM based, as requested by your program directors. All right, team 1, you have the board. Mayo.
All right, we'll do name that shunt for 100.
Name that shunt for 100. All right, here we go. The specific name given to the original subclavian artery to pulmonary artery shunt. The original.
Team 5.
Team 5. OHSU.
Go, Babakar.
Blalock-Taussig shunt.
Yes, that is correct. But once again, reminder, try and frame it in the form of a question. Makes it a little bit more exciting. All right, so yeah, the story behind the Blalock-Taussig shunt is fascinating. It's worth definitely reading for the history buffs and all that. I know one of you was a history buff. Medical history is a lot of fun too.
Yeah, sure.
Okay, so that was team 5, right? OHSU?
Yeah, we'll go shunts 300.
Name the shunt 300. Right, here we go. The specific name of the superior vena cava to right pulmonary artery shunt.
Team 5.
What is a Glenn shunt?
Yes, that's correct. Yeah, you guys are shunt fanatics. Glenn shunt, SVC to our right PA. All right, team 5, you have the board.
We'll go shunts 400.
400. The specific name of an ascending aorta to right pulmonary artery anastomosis. So the other.
Team 1.
Team 1, Mayo.
What is the Watterson shunt?
Yes, that is correct. Well done. Watterson on the left and Potts on the right. All right, going back to the board. Mayo, you have the board.
Pharmacology. All right. Pharmacology for 100.
Pharmacology for 100. All right, the Vaughan-Williams classification scheme. Match the electrophysiology effect with the ion channel affected. So, for example, slow sinus node automaticity, slow AV node conduction, beta adrenergic receptor, and that's a class 2. So, delay repolarization by prolonging phase 3 of cardiac action potential, and this is the ion channel, right? The ion channel that's involved.
Team 1.
Mayo?
What is the potassium channel?
That is correct. This is the potassium channel. Good. All right. Go back to the board. And yeah, you know, this delay repolarization, that's a Vaughan-Williams class 3 drug, right? Going back to the board. Mayo?
Pharmacology for 200.
Pharmacology for 200. The pro-arrhythmic effect of class 3 anti-arrhythmic drugs is maximal at blank heart rates.
Team 5.
Team 5. That's OHSU. OHSU.
What is a slow heart rate?
Yeah. What is lower heart rates? That's correct. Yeah. Yeah. So class 3 drugs, as we all know, exhibit reverse use dependence in which a greater degree of channel block is seen at slower heart rates. So therefore, the pro-arrhythmic effect of class 3 drugs is due to the excessive prolongation of the QT interval, leading to a predilection for polymorphic, actually for torsades, right? And the pro-arrhythmic effect, therefore, is maximal at slow heart rates. Good. OHSU, you have the board.
Pharmacology 300.
Pharmacology for 300. Okay, drug interaction can lead to an increase or reduction in blood levels of certain drugs. Citalopram has this effect on lidocaine blood levels.
Team 7.
Team 7, Utah.
What is increased?
What is increased? That is correct. Here you go. Yep. So lidocaine is metabolized by the CYP2D6 cytochrome P450 system. Drugs that therefore inhibit CYP2D6, such as amio and citalopram, will raise lidocaine levels. All right, good. All right, team 7, board.
Vascular. Let's go with vascular disease for 200.
Vascular disease for 200. Okay. Polyarthritis nodosa is a vasculitis that predominantly affects what size vessels?
Team 5.
What is medium-sized vessels?
Yes, that is correct. Team 5. Team 5 is OHSU. Good job. So yeah, PAN affects medium-sized vessels, including the coronary arteries, and that's in distinction to Takayasu, which is aorta, the great vessels, giant cell, which is aorta and great vessels, and then Kawasaki, which is almost, all coronary vessels. Good. Did you guys know that Anthony Fauci was, I think, the first person to come up with the use of chemotherapeutic agents for vasculitis? That's what he's really famous for. And now COVID-19. I learned that on my drive to New Mexico last week. All right, that was team 5, right? OHSU?
Go pharmacology 400.
Pharmacology for 400. Adenosine is used to terminate paroxysmal SVTs, which is AV nodal dependent. Match the effect of adenosine with each of these situations. So when you have pyridamol, you potentiate adenosine effect. With methylxanthines, you have no adenosine effect because it's a competitive antagonist, just like caffeine is. In the transplanted heart, is there an effect on adenosine?
Team 5.
Team 5, OHSU.
Is it an exaggerated effect?
Yes, that's right. It's an increased adenosine effect. It's a potentiated adenosine effect. 1, 2, 3, 4, 5. 3 guys. Yes, good. That's a good one. I had to look that up. That's good. Team 5.
Go vascular disease for 100.
Yeah.
Okay, vascular disease for 100. The mainstay treatment for Buerger's disease, thromboangiitis obliterans, is
Team 5.
What is smoking cessation?
Yeah, excellent. Team 5, you guys are rocking this. What is smoking cessation? Yeah, as you all know, thromboangiitis obliterans, segmental non-atherosclerotic inflammatory condition, affects the small and medium-sized arteries. More common in men, very closely linked to tobacco use, and therefore cessation of tobacco is the prime form of treatment. Okay, Team 5.
Vascular for 300.
Vascular for 300. Is everybody's buzzers working, by the way? I just want to make sure. No issues, right? Buzzers all good? All right.
We switched just now if you want to try it.
We can do a test run just to see.
Yeah, let's do a test run.
Okay.
Yeah, I feel like we're buzzing right away and it never does anything.
Yeah, the Wi-Fi is just really good in Oregon.
Yeah, we're like always way
We're like
Very aggressive.
That's funny.
I'll say
let's
on,
test it out. Let's test
on
it
the
out.
last question, 6 teams buzzed in that I saw, but we can check everybody's right now. So on 3, 1, 2, 3. So I have team 1, 2, 3, 4, 5, 6, 7. Yep, everybody's works.
Everybody's works. Okay. All right. Yeah. You guys are just somebody's like very fast on the finger there in Oregon. All right. Our OHSU. That's the guy. All right. Choose the next category, please.
Vascular 300.
All right. The clinical etiology anatomic pathophysiology classification (CEAP) is used to assess the severity of chronic venous insufficiency. Varicose veins are C2. Heel ulcerations are
no responders.
No responders.
Wow.
Somebody's waving, but
oh wait, 3 just responded.
Okay, so
What is C4?
that is incorrect. Okay, I think nobody else. Did anybody else respond? No. All right. Yeah, this one is, you just have to memorize it,
You
unfortunately.
guys took off points from us and we didn't answer that question.
Oh, I'm sorry. Yes, correct. Thank you for pointing that out. Do I need to go back to the board to do that? Yes.
That is correct.
Okay,
You
I'm
can
going to
adjust
go back
it.
to the board. Okay. And that was a minus 300, right? Yeah. So I'm going to adjust scores here. All right. So you guys are at 100. Player 4 is at 100, right? And then player 3, which is Tucson, is minus 100.
Minus 300.
Yeah, you guys were minus 200. That was minus 300. So you're back to 100 again, right? Letitia, you want to confirm that before?
Yeah, I had it at minus 200 for team 2.
Okay. Minus 200 for team 2 is correct. It's the exchange between Tucson, which is that was a minus what, 300, right?
It was minus 300.
Yeah. So
the player was saying though.
okay. All right. So Tucson is minus 300, right?
Yes.
Okay. Let me make sure we get that right. There. Is that better?
That's what I have.
Okay. Great. So all right. Let's keep going then. And so it goes back. The control of the board goes back to OHSU team 5.
Do vascular 400.
Vascular for 400. A 45-year-old carpenter has this syndrome.
Team 3.
What is Berger syndrome?
No, that is incorrect.
Team 2.
The occupation is important here. Team 2. Yeah.
What
Team
is
2.
thrombolysis obliterans?
No, that's incorrect. No.
Team 4.
Yeah, New Mexico. Team 4.
Sorry, what is subclavian steel?
No, sorry. Good try, guys. It does look like that. That's for sure. I do agree that it does look like this, but this one is hypothenar hammer syndrome. This is very vascular subspecialty, and I had to go look this one up too. But this is a result of repetitive blunt trauma with the hypothenar eminence. Apparently, amongst vascular medicine specialists, this is like something that's commonly known. And it occurs at the site where the ulnar artery crosses the hamate bone. And then as you do this a lot, it actually causes thrombosis or aneurysm of the ulnar artery. And then treatment is antithrombotics, but it can lead specifically to digital emboli, ischemia, and gangrene, as demonstrated by the previous picture of the ulnar artery supplied vessels. Good. Wow, that was a good one. All right, I think it's back to OHSU Team 5 again. You guys?
Genetics 300.
Genetics 300. Okay, match the long QT syndrome with the gene mutation. LQT3, SCN5A, LQT2, KCNH2, LQT1.
Team 2.
Phoenix.
What is KCNQ2? I mean Q1. Sorry, Q1.
Oh, okay, good. Good, excellent. Yeah, you guys. Good job for the last minute. Excellent, fantastic.
Yeah, Q1.
There we go. Yes. What is KCNQ1? I hate these kind of questions because you just have to know them or you don't. But well, all right. Team 2, you have the board.
We'll finish out genetics 400.
All right, genetics for 400. Oh, this is the daily double. So the maximum wagerable amount is 400, right? Yes, the maximum wager amount is 400. And this question is only open to Team 2. So Team 2, what is your wager?
We'll bet 200.
200, okay. All right, go. All right, match the gene mutation with the cardiomyopathy. MYH7, which is the beta-myosin heavy chain, that's hypertrophic cardiomyopathy. Desmosomal protein plakophilin 2, PKP2, and it is this cardiomyopathy.
What is ARVC?
Yeah, excellent. Good job, guys. Yeah. All right, Team 2, right, yes. Yes, what is arrhythmogenic right ventricular dysplasia or cardiomyopathy? There are some other gene mutations such as desmocolin 2, desmoplakin, et cetera, et cetera. Gene mutations have been identified in only 50% of ARVD cases, unlike some of the other diseases. Thus, a negative genetic test does not rule out ARVD. Okay, now we're going back. Team 2, you have the board.
We'll do cardiac conundrums for 100.
100 cardiac conundrums. The cause of hypertension in this 40-year-old female is?
Team 2.
Team 2.
What is fibromuscular dysplasia?
Excellent, yeah. Your internet is suddenly much faster than organs. Exactly. Yeah, so the renal angiogram shows the characteristic beaded appearance of the renal artery in FMD, which should always be suspected in cases of hypertension in young women. So this is a pretty common disease. Good. All right. Team 2.
We'll do cardiac conundrums for 200.
Cardiac conundrums for 200. In hypertrophic obstructive cardiomyopathy, X happens to the murmur and Y happens to the carotid impulse in the post-PVC beat.
Team 1.
Team 1, Mayo.
Increase happens to the murmur and reduction in pulse pressure happens to the carotid impulse.
Excellent, good. A reminder, answer in the form of a question. Oh, well done. This is a classic, and we all know this, especially interventional people. All right, Mayo, conundrum?
Yeah, cardiac conundrums for 300.
300. The two most common mutations leading to hypertrophic cardiomyopathy are, and we need the two of them.
No responders at the moment.
If you don't know the mutation, what about the proteins? You can also answer in the form of the actual proteins. Okay, yeah, I didn't think anyone would get this. So the two most common mutations, and there are a lot of them, but 80% of all the mutations are accounted for by MYH7, which actually showed up in an earlier question, beta myosin heavy chain, and myosin binding protein C, MYBPC3, and those have the equivalent distribution. All right, there's no other choice on the board, so we are going for cardiac conundrums 400. I'm making the decision for you, Mayo. Here we go, last question. Name this ECG pattern, I'm speaking slowly, and the disease process it represents. Go.
Team 4.
Team 4, that's New Mexico.
What is electrical alternans and what is tamponade?
Okay, we'll accept it. It's actually it's not necessarily tamponade, it's just a large pericardial effusion. It doesn't have tamponade. It's just the fact that the heart can swing back and forth in that space. But yeah, we'll take that. It's fine. All right, and that concludes our first single Jeopardy session. Well done.
Okay.
Right.
We will take a 5-minute break. And during the break, we'll do an audience question where we'll be giving away a $30 Amazon gift card for the audience members.
And does the audience include the players? No.
No, it doesn't.
Okay, great. Yeah,
All right.
and don't forget to type your little answers there. Do I have it? Let me see. Come on, yes.
So I think you stop sharing your screen on your side, and then I can share the screen with the audience question.
Perfect. I'm stopping my share.
So it's 2:24 right now. So our 5 minutes will bring us back right around 2:30 my time, Central Time.
All right, we just this is team 1. We just switched our phone. My phone was having issues. Can we just test the buzzers once more if that's okay? Sorry.
Sure. I'll open the buzzer and you guys can buzz in and we'll see if it works. All right. So it's open right now. There it is. I see it.
Okay. Thank
Okay,
you.
great. All right. I'll share my screen.
Dr. Lee, we had a quick question.
Yeah.
For that daily double, if we got it correct, do we get double the 200 points or just 200 points?
That is a good question. Nikechi.
Yeah, so the software will only give you the amounts that you wagered. That's just the way the software was built. So I apologize. That's all we can do at this moment.
Okay, just one.
Can I give them an additional 200? Would that be unfair? I can the amount.
No, it's fine because the next it'll be okay. Just leave it as.
Okay, all right. Sorry, guys.
Okay. All right, so we can do our audience question. 1 second for me. So I'm going to present a question to the audience. Audience members should submit their answers in the chat box. And the first correct answer will win a $30 Amazon gift card, like I said, okay? So get ready. the specific diagnosis in this asymptomatic 18-year-old male? Give a couple seconds.
You have to win.
Ooh. A couple folks have come through. Okay.
I'm sending you the email.
All right, so let's see what the answer is. What is dextrocardia? Nice job. There's a lot of people that got that answer right, but the first person that got it right was Natalia Natalia Andonovich.
Oh, well done, Natalia, wherever you are.
So congratulations, Natalia. You get a $30 Amazon gift card. We'll reach out to you, get your contact information so we can get that to you.
Oh yeah, I see some of our teams also answered that question. That question was for the audience. But yeah, we'll use this opportunity to remind everybody later on for the final Jeopardy as well, because it does require messaging to not message in the common chat group, okay? And for the audience to stay silent, unfortunately, on that one. We love audience participation, but not for that.
Yeah, I was an audience, by the way.
Oh, you were? Good.
From Utah.
Oh, from Utah, hey. Hi. Okay. All right, Brian, let us know when lunch or coffee breaks are over.
Okay. I'll give it about 30 more seconds or so.
Okay, hold on. I'm going to take a picture of this thing just in case my scores don't follow me over. Okay. And more trivia, the medical school Katie Murphy was referring to was Trinity College in Dublin, Ireland. It's where I went to medical school. I don't look Irish, do I?
No, you don't.
A little bit.
Yeah, they call me a leprechaun. All right, looks like everyone's back.
Yeah, I think we can get back, get started.
Yep, let's jump over to round 2. Here we go. I'm going to double. Sorry, trying to get us back to share screen. Here we go. Ready? There we go. All right, welcome back to the double. Okay, who was last? Was it New Mexico?
We'll do essential oils for 600.
Okay, essential oils for 600. Here we go. The primary target of action of ezetimibe is one of these 4. Yeah, this is my fault. I'm sorry. We were supposed to write questions, not in MCQ form, but I get the memo, so causing trouble as usual. But just make your life easier.
Team 2.
Team 2, Phoenix.
What is fatty acid transport protein?
No, unfortunately, that's incorrect.
All right. Team 1.
What is choice D, Niemann-Pick C1-like protein?
Yes, that is correct. Yeah. Good job. Yeah, so Niemann-Pick C1-like protein is a protein that lives in the jejunal brush border and is integral to the uptake of intestinal lumen cells into the enterocyte. It doesn't affect, for some reason, triglyceride uptake. I'm not sure why, because a lot of triglycerides are transported by chylomicrons, which is interesting. Yeah, it's a very strange protein name. I don't know why it's named so long. I didn't get a chance to look up the trivia as to who Niemann or Pick were. But there it is. All right, Mayo, team 1.
Oval Office for 200.
Oval Office for 200. Yeah, Oval Office has gained a really a totally new meaning since I wrote this question. The minimum recommended duration to rule out atrial fibrillation when evaluating patients with cryptogenic stroke and PFO is A, not necessary to rule out, B, Holter monitor for 24 hours, C, event recorder for 28 days, and D, loop recorder for 6 months of monitoring.
Team 5.
What is
OHSU?
Recorder for 28 days?
Correct, that's correct. Team 5, 1, 2, 3, 4, 5. Yeah, the PFO stuff, there's been a recent American Academy of Neurology practice guidelines. They finally got on board, right? We tried to close these holes for years. They said no for a while. We said no for a while. And then recently, all of that changed. I think it's the first time well, not the first time, but one of the few times in history where we went from class 3 recommendation to a class 1 recommendation in the space of a few years. So yeah, it's important to know about this. So the AAN PFO practice statement advisory says that select patients being considered for PFO closure thought to be at risk of atrial fibrillation should receive prolonged monitoring for at least 28 days. Although if you look at the literature, in people with cryptogenic stroke, with prolonged monitoring, quite a fair bit of people end up having atrial fibrillation as the potential etiology instead of PFO. So that's an interesting one. All right, that was was it 5 or 4? I can't remember. Was it OHSU?
Yeah.
Yeah, so get to the board. Go.
Can you hear it? We're having some internet issues. Can you hear us okay?
Yeah, I can hear you now.
We'll go Oval Office for 400.
Oval Office for 400. Okay, which of the following increases the ROPE score or the risk of paradoxical embolism score? A, history of diabetes, B, presence of atrial septal aneurysm, C, large right to left shunt on PFO imaging, and D, cortical infarct on imaging.
Team 3.
Tucson?
What is B?
Presence of atrial, B as in boy?
Yeah.
Yeah, that is incorrect. Did anybody else answer, Brian?
Team 7.
7, Utah. You guys are big in PFO closure. Utah? We didn't answer.
It is A.
No, that is incorrect as well, unfortunately.
Team 4 was 3rd.
We're gonna say C, large right to left shunt.
What is C?
What is C?
Team 4? No, unfortunately, that's incorrect. Oh no! Oh, best laid plans. So yeah, the ROPE score was put together in 2013 by David Thaler's group out of Boston, and it was an attempt to estimate the probability that a cryptogenic stroke was related to PFO. And it's a pretty robust score that has been validated numerous times ever since then. And a score less than equal to 7 suggests that the cryptogenic stroke was PFO related. The diabetes was a good guess, but it actually is a negative for diabetes, as in if you have a history of diabetes, you are more likely to have a stroke that's not caused by the PFO. So it actually decreases your score. The cortical infarct on imaging is a very important thing because a lot of patients have lacuna strokes, right? And a lacuna stroke is not an embolic stroke. And that's why I want to specifically make that distinction. Unfortunately, this score, they did not have the data at the time to integrate the size of the PFO. They didn't have anything to be able to pull in atrial septal aneurysm. And it does not account for unique situations where you have a shunt and a history of a DVT and PE, or the classic clinical Valsalva at stroke onset or hypercoagulable state. So this is a very interesting score that I thought people should know about. I'm sorry it has cost you points, but you know, it's in the AAN recommendation. Okay, who? Everybody got that wrong. So who was in charge last? I think it was.
I think it was us on 5.
Oval Office 600.
Okay, Oval Office 600. Oh, this is the daily double. All right. Yeah, so only you guys get to answer this. The maximum wageable amount, you guys are, oh, you have 1,500, right? Catchy, do they get, is it still 800, the maximum wageable, or can they wager up to even 1,500?
They can wager all of their money if they want to. They can wager up to 1,500.
Oh, wow, Nevada, Vegas. All right, OHSU. How much would you like to wager? And don't forget, this is not a double. So New Mexico brought that up earlier. Whatever the amount that you wager is the amount that you can get. It's not
400.
Yeah.
400. Okay. Conservative. Nice. Okay, go. Which PFO closure device was studied in the Closure 1 trial? A, the Helix septal occluder, B, the Cardioform septal occluder, C, the Star Flex septal occluder, or D, the Amplatzer septal occluder.
What is D, the Amplatzer?
Oh, no, sorry, that's wrong. So, yeah, the Closure 1 trial was infamous because it specifically studied the Star Flex device. This was published in New England Journal as the first of the PFO randomized trials back in 2012, and it was a negative trial. And the reason, you know, I think there is some need to know about the different closure devices is because PFA closure, unlike stenting for the most part, is device specific, right? The results are not the same depending on the device that was chosen. And, you know, enough patients will enroll or receive this that you will still see patients nowadays who actually have a StarFlex device. And it's a very characteristic looking device. It looks like two squares put up against each other like a star. And it's very much more bulky compared to the Amplatzer and the Helix. Okay, it's still you guys, OHSU, Team 5.
Oval Office 800.
Wow, going back to the source of the pain. Okay, a chest CT was obtained from a patient thought to have a PFO, and that this structure was seen in the lung. Okay. What additional disease should be considered? A, Wyburn-Mason syndrome, and then B, B is not C. B and C are the same thing. Hereditary hemorrhagic telangiectasia is B. C is Kawasaki disease, and D is carcinoid syndrome. So when you choose your answer later, call out what you're saying instead of the ABCD. All right, go.
Team 1.
Team 1, Mayo.
What is choice B? Hereditary hemorrhagic telangiectasia.
Good, excellent. That's a good. That's very good. So HHT, pulmonary AVMs and strokes, right? These are rare causes of paradoxal right to left shunting, second to PFO. What they even found was that in PFO patients with successful PFO closure, when they were followed up at 1 year, there was like 3 or 4% of them had persistent shunting. And when that was investigated, it turned out to be that they also had pulmonary AVMs. Very low prevalence, 1 in 2,630. 80% of pulmonary AVMs occur with HHT, and they're usually multiple. The genetic abnormality you can actually test for this in HHT is the ENG or ACVRL1 gene, 80% of patients. And the estimate overall is that 25% of patients with pulmonary AVMs that are untreated will eventually have a stroke as long as the AVMs are large, and the risk correlates with the shunt size. Okay, Mayo, you have the board.
Okay, narrow it down for 200.
Narrow down for 200. Okay, the gradient threshold for severe pulmonary stenosis is A, peak gradient of 40 millimeters, B, peak gradient of 36 millimeters, C, peak gradient of 64, or D, the mean gradient of 40.
Team 3.
Team
What is
3,
C?
Tucson. 6, was that confirmed?
What is D, 64?
Yes, that's correct. The peak gradient of 64 millimeters mercury. So it's team 3. Yeah, and this is always confusing. But for severity of RVOT obstruction in the most recent updated, or actually no, in the 2018 congenital heart disease guidelines is a peak gradient of 64. They do make allowances for a mean gradient of 35, but it's primarily driven by peak gradients in the grading of severity for PS. Okay, Tucson, team 3.
Let's go narrow down for 400.
Narrow down for 400. Okay, an elderly patient with a mechanical AVR presents with sudden class 3 dyspnea after running out of warfarin. He has no contraindications to thrombolysis. He declined surgery, so we obviously have to thrombolyze him. The optimal dose of thrombolysis is A, 40 milligrams of IV tenecteplase as a bolus, B, 100 milligrams of TPA IV over 6 hours, C, 25 milligrams IV TPA over 6 hours, or D, 25 milligrams TPA over 25 hours.
Team 6.
Team 6, OHSU blend, the good wine.
We'll say B.
TPA over 6 hours? No, that is incorrect, unfortunately.
Team 3.
What is C? 25 TPA over 6 hours?
No, that is also incorrect, unfortunately.
Team 4.
Team 4, New Mexico.
What is A?
No, unfortunately, also that is also correct, incorrect. So this one was fascinating. I actually had to look it up as well because this is the new 2020 guidelines. The reason, unfortunately, I put this one up because I actually saw a patient like this and I had to go find out whether it covered the new 2020 guidelines. But this is a level 1 guideline, level evidence B, for patients with a thrombosed left-sided mechanical prosthetic heart valve present with symptoms of valve obstruction. Urgent initial treatment with either slow infusion, low-dose fibrinolytic therapy, or emergency surgery is recommended. And this recommendation was based out of Turkey, and there was actually a trial. They did actually study the question. And the group in Turkey, and both papers were published in JACC Imaging, basically started off, nobody knew what the right answer was in the beginning. So they started off with full dose, single bolus, and what they did was they bracketed their care and outcomes over several years, right? So the first 3 years, they took everybody, they gave them a full blown, and then they noticed that the bleed rate for that is obviously extremely high. So then they moved downstream and said, well, let's take that dose and let's stretch it out. And what they found was still high. So then they stretched it out some more, and then they finally stretched it out for 1 milligram per hour for 25 hours. And what they did then was they repeated that cycle over and over again until they got the results that they wanted. And on average, patients had 4 to 5 rounds of this 25 milligram per 25 hour cycle. But then they would do it, repeat and echo, do it, repeat and echo. And they were able to push down the complication rate to an extremely low level while still achieving a pretty high rate of resolution of a stuck valve. And that was pretty impressive. But the strange part with the guidelines is that they don't actually list out what the dosing regimen is, which I thought was interesting. But sorry about that, but I thought we'll learn something here. I learned something for sure. Okay, long chat, but who was up? Was it Mayo or? I can't remember, I lost track. Who has the board?
I think we do.
We do?
Yeah, because everybody got it wrong.
Me for 200.
Was that what you want?
Support me.
Okay, support me for 200. Okay, here we go. Everyone ready? Watch this. The pulmonary artery pulsatility index formula is defined as?
Team 4.
New Mexico.
So PA systolic minus PA diastolic over CVP.
Yes, that is correct. So team 4, New Mexico got that right. Oh, I'm sorry, I'm trying to get rid of my control and I want to score you, but the Zoom control is getting in the way. So yes, this is, I think, well known to most of us at this point in cardiology fellowship. PA systolic minus diastolic over right atrial pressure. A PAPI of less than 1 is indicative of significant RV failure and cardiogenic shock. And that number actually moves back and forth depending on the situation that you're looking at it. So that's important to also know it's a fixed number. All right, team 4, you have the board.
So we'll do support me for 400.
Support me for 400. Okay, a 55-year-old man presents with an inferior MI and undergoes proximal RCA PCI. During PCI, he transiently has ventricular fibrillation requiring cardioversion. His systolic blood pressure is 88 millimeters mercury. Hemodynamics from a Swan-Ganz catheter are: CVP is elevated at 20. His wedge is 10. His cardiac index is 2.8 liters per minute per meter squared. His SCAI stage of cardiogenic shock is.
Team 7.
Utah.
What is D?
What is that?
D.
B for boy or D for dog?
D for dog.
No, that is incorrect.
Team 6.
Blend OHSU.
B for boy.
B for boy is any modifications to that?
How many P fellow?
Okay. No, I'm sorry, we cannot accept that. Good try though, EP fellow.
Team 3.
What is C?
No, that is also incorrect. Okay, so yeah, the reason why B is actually correct, but when you have a cardiac arrest, the current guidelines add a modifier to that. It's BA. The reason it's BA, and you would be surprised given that the CVP is high, but in the B group, you know, they are looking at the cardiac index, which is okay, right? So, and it's up here. But yeah, if you have an elevated JVP, you can still be in stage B, but they don't have an elevated wedge, they don't have an elevated cardiac index, and then this A modifier is very important because no matter how transient the cardiac arrest is, right, it has quite a significant impact on outcomes. It is a magnifier of the stage. Okay, so, all right, I lost track. Who was that?
So I think that was ours. We're gonna do support me for 600.
Okay, that's New Mexico, right? Yeah, okay, support me for 600. The 65-year-old man is admitted with chest pain and dyspnea because suddenly becomes hypoxic, requiring intubation, and hypotensive, requiring vasopressors. A PA catheter shows this tracing in the wedge position. His diagnosis is. Go.
Team 7.
Team 7, Utah.
What is acute severe mitral regurgitation?
Yes, that's correct. Yeah, huge, massive V wave, as you can see. Good job, guys. What is acute severe mitral regurgitation? I've seen a few of these. Very unpleasant to deal with.
Yeah, no, I agree with you. Utah, I think so.
All right, team 7, you have the board.
Close out, support me for 800.
Okay, support me for 800. Oh, it is the daily double.
How much can we wait?
Excited myself. So the maximum wager for, was it team 7, right?
Yeah.
Yeah, is 800, right? Because yours is 300 maximum, but we can take the maximum on the board. And you are the only people who can.
800.
How much?
We'll wager 800.
All right, I like this. Wow. Extreme sports. All right, ready? Go. Of the options below, this mechanical circulatory support device is capable of providing the highest flow. A, Impella 5.5, B, VA ECMO, C, tandem heart, or D, Impella RP. Do I have to make the music come on, or?
A.
Unfortunately, that is incorrect. So VA ECMO has the highest. That can go up to 7 liters per minute. Impeller 5.5 of the impellers is the highest at 5.5. Then you have the RP and tandem heart, and they're all about 4 liters per minute. Oh, sorry, I need a power cable. Give me a second. All right. Okay, I think it's still team 7, right? Utah, you still have the board. Utah?
Essential oils for 800.
Okay, essential oils for 800. Okay, several biomarkers are associated with increased ASCVD risk and are designated risk enhancing factors. So these are beyond your usual lipid stuff. So an elevated high sensitivity CRP greater or equal to 2.0 milligrams per deciliter, and elevated lipoprotein A of greater than or equal to 50 milligrams per deciliter, or an elevated ApoB blank milligrams per deciliter. Go.
Team 2.
Team 2, Banner Phoenix.
What is 130?
Yes, excellent. Good job. Wow, fantastic. So yeah, this is a very interesting one. For those of you who don't know, ApoB is a rapid, has been in the background, but really rapidly emerging additional biomarker. It has some benefits over LDL, etc., because every lipoprotein particle has only one ApoB, while the number of each lipoprotein particle can have different amounts of cholesterol and triglycerides in it. But it's the number of particles that get trapped in the walls that really actually ultimately count. So in all the recent studies, ApoB, which is not a very expensive test actually, and doesn't require you to be fasting, because the number of those particles is about the same. The number of cholesterol in it causes flux, but ApoB has been shown to be a better risk predictor biomarker than even LDL. So that's an interesting one. So ApoB, a new friend emerging, lots of papers on it recently. Okay. Whenever I talk so much, I forget who was last.
We'll do it's Banner Phoenix. We'll do 400 essential oils.
Okay, Banner Phoenix essential oils for 400. Thank you for keeping track and keeping us online.
No problem.
Okay, the most frequent cause of familial hypercholesteremia is due to mutation in this gene, either A, PCSK9, B, ApoB, or C, LDL receptor.
Team 5.
Team 5.
C, LDL receptor.
Yeah, excellent, good. Yeah, most of the familial, team 5, 1, 2, 3, 4, 5. Yeah, most of it is LDL. PCSK9 and ApoB are much less. I think it's almost like a 90%, right, of all familial dyslipidemia is based off LDL. Okay, OHSU, team 5.
Do oils for 200.
Oils for 200. The goal of high-intensity statin treatment in a 65-year-old patient with clinical ASCVD is to reduce baseline LDL-C by, and this is a class 1 recommendation.
Need to reset the buzzer.
Sorry about that. That was my fault.
Okay. Okay, buzzer going now. Did you get it?
Team 5.
Team 5, OHSU again.
By greater than 50%.
Yeah, excellent, good. Yeah, you guys are like the buzzer experts. Wow. Yeah, patients about 75 years of age or younger with clinical CVD, the aim should be a good 50% or greater reduction in LDL-C. Good job. Okay, team 5.
Narrowed down for 800.
Narrowed down for 800. Using the Sievers bicuspid aortic valve classification, the bicuspid aortic valve morphology associated with the best TAVR outcome is blank.
Team 7.
Utah. Utah?
What is right and left?
No. Remember Sievers classification. We need a Sievers It's not calcification, it's classification.
I think we missed that one.
Yeah. What? No. Okay, who's next? No, it's not Utah, so let me.
All right, team 2.
Phoenix.
Sievers type 1.
No.
Team 3.
What is type 2?
No. So it's Sievers type 0. There's a 0, unfortunately, guys. 0, 1, and 2. And that was a good guess, 1 and 2, but there is actually a 0. It's there's a brilliant paper by Raj Makar's group recently that shows that it's not just the 0, but the 0 as a whole. Without the RAFE is best. But he did show that if you have a lot of calcium in a 0, for example, versus a type 1 with no calcium, it's possible that the 0 with the more calcium is the one that's worse. So it's a combination of both the amount of calcification and the Sievers subtype. So Sievers 0, not much calcium is probably the best, but then you ask why are they stenosis, right? So, yeah. Okay, what was it? Can't remember again.
So narrowed down 600.
600, okay. Narrowed down for 600. So this parameter suggests severe aortic stenosis in a patient with an ejection fraction of 60%, a valve area of 0.8 centimeters squared, and a peak velocity of 3.2 meters per second. So you still think that this patient has severe AS. Which of the following would it be? A, stroke volume index of 30 milliliters per meter squared. B, Agatston score of 1700 in a man. C, Agatston score of 1100 in a woman. Or D, a systolic blood pressure of 150 millimeters mercury during the time of evaluation. Go.
Team 2.
Team 2, Phoenix.
What is stroke volume index 30
Yes,
ml?
excellent. Yeah, yeah. So this is a paradoxical low gradient, low flow severe AS. And the criteria that you have to, and therefore when you're writing your echo reports, you're trying to suggest to someone, you do need to take into account this, right? And so you do need to add that to your, for it to be a good report. If you're trying, this is what we're trying to suggest to our readers. And you have to measure when the patient is also normotensive, because if obviously the patient is hypertensive, it will suppress the gradient. The Agatston score, there's sex differences in this. And instead of trying to bring the patient for a calf to work out that number, the other way to do it is to get a CT TAVR workup protocol, and the score is greater than 1300 for women and greater than 2000 for men. If that's more than that calcium, you can still call it without doing more tests to your patients. Did I give you the score? I'm sorry. I think I did, right?
Yes.
Yeah, you did.
Yes. Yes.
Okay, so that was Banner Phoenix, right? I got that.
B spontaneous for 200.
B spontaneous for 200. Spontaneous coronary artery dissection occurs most commonly in this coronary artery. Go.
Team 4.
What is the LAD?
Yes, excellent. Good job. The LAD. LAD is most common, about 1/3 to a half. Circumflex is next, about 1/8 to about less than a half. And the RCA is less common. And the left main is actually very uncommon as a spontaneous dissection. Obviously, as a guide-induced dissection, it's less common than the right, but still, depending on what you're up to. Okay, go again.
We'll go with B spontaneous for 600.
All right, good. Of the 3 images provided, identify the angiographic appearance most common with scan. A, B, or C. Go.
Team 2.
Team 2, Phoenix.
What is B?
B as in boy?
I thought I heard 2 answers. Are you saying B, boy?
B, boy.
B boy, yeah.
Yeah, that's incorrect. Who's next?
Team 4.
Team 4, New Mexico.
What is A?
No, that is also incorrect.
Team 3.
Team 3, two.
What is C?
Yeah. That's also quite unfair because there's no other option. But yes, that is correct answer. As we all know from Jacqueline Sau's classification, there's 3 types of SCAD, right? The focal type with the very classical little tear, and then this long type 2 diffuse disease thing. And then you have this one's very difficult to differentiate type 3 from just regular run-of-the-mill coronary artery disease. Type 2 is the most common, 68%. Obviously, it also depends on how often you are recognizing the disease to start with. Because, you know, before Jacqueline and Esther Kim, etc., started to write these papers, many of us, I've seen angiographic reports, even at our institution, where someone said no significant disease, LAD diminutive, on a patient that looked exactly like this, right? But when you image this, what you'll find is that, you know, this is actually a very long dissection. And cardiac MRI helps you not miss things like this too. So, good.
All right, let's take 400, be spontaneous.
Okay. This condition is the most strongly associated with SCAD. A, pregnancy, B, Marfan syndrome, C, fibromuscular dysplasia, and D, multiparity. Go.
Team 2.
Team 2, Phoenix.
What is C?
Yes, good. Excellent. Team 2 got it right. Yeah, so fibromuscular dysplasia is the condition that's most commonly found when you start looking for a secondary backup condition in patients who present with SCAD, 25 to 86%. Pregnancy, multiparity, these are all risk factors, but they're definitely not as common as FMD. And then Marfan's is also, you know, obviously a patient who presents with Marfan's, who has known Marfan's, who presents with one of these, this is most likely the underlying problem, but FMD is by far the most. Okay, last one. Right, everyone. Yep.
Spontaneous for 800.
Go. SCAD vascular screening would most likely reveal abnormalities in this arterial territory. A, the extracranial carotids. B, intracranial aneurysms. C, renal arteries. Or D, subclavian arteries. Go.
Team 4.
Team 4.
What is B, intracranial aneurysm?
No, unfortunately, no, guys. New Mexico, sorry, that's not the right answer.
Team 2.
What is C?
Yes, that is correct. Yep, renal arteries is correct. So FMD is because FMD is the most common condition. Renal arteries therefore have the most. You know, a lot of patients with FMD have the issue. So 80%. You'll find that in the extracranial, and then intracranial aneurysm is a thing, but you know, because FMD is not the biggest risk factor, you know, I mean, it is the biggest risk factor. They're not that often found when you look for. Okay, and that concludes the double jeopardy section of this, and we are now going to move on to the final jeopardy, right? Kechi, I'm going to press the button. Is that what I do now?
Yes, you can go ahead. Thank you so much.
Press the button. Nothing happened. Try again. Okay, the final jeopardy. Okay, so just as a reminder, I think only the people who have positive scores are allowed to bet in this round. So that would be Mayo, Arizona at $2,300, Phoenix at $600, and 1, 2, 3, 4, 5. OHSU at 1,700, right? The maximum allowable is the amount that you have, right? For your bet. Don't forget, you have to message me how much you would like to bet, and the title of this thing is Amazing Angiograms. And then message me privately what the answer is. The rest of you, audience is included, please refrain from getting very excited and telling us what the answer is before the teams have a chance to play it out. Nkechi, when did they make their bets? Now or later?
They can make their bets now before you show the question.
Okay. So text me or message me. Oh, no. Oh, okay, hold on. I have to quickly get back to my view because I've messed this up.
So you go back to slideshow from current slide. So yeah.
I know. See, I told you actually you can definitely rely on me to mess things up.
You're doing a great job at doing it well.
Well, I'm messing it up well.
No, I'm doing it well. We really enjoyed the presentation. Arizona banner, I think you need to send it to Dr. Kwan, not to me though. It's to be Kwan Lee that you need to send your bet to.
Yeah, I don't see my message box though. That's why I ended up messing around with that thing.
Oh.
Where's my message box? Here. Is it Q&A?
No, the chat box would be.
Okay. Yeah, that's the reason why I ended up doing that, because I was looking for my chat box and I cannot find it. Up to my controls, I'm hitting chat, but it's hidden somewhere. Hold on. What should I do to find my chat box?
If you're on a dual screen, it probably is on the other screen, maybe.
No, I'm not on dual screen. I'm not. Does everybody mind texting me instead? Yeah, I'm gonna write my phone number on the wall, like in the restroom or something.
If you want to, or you can send it to the scorekeeper. Letitia is still here. It's up to you.
Okay,
or you can send
yeah.
it. Or they can send.
Yeah.
It's only 4 teams. You want to paste your cell phone? That's okay. They can send it to you, but you can also send it to Letitia. And she can. What she'll do is to adjust the scores at the end.
Okay, Letitia, why don't you do that? Just so that.
You bet.
I'm sorry, what? So what was the final decision?
So we are going to send a message of how much you would like to bet to Letitia, who will run the score, because I cannot see the chat box.
Okay. My last name's Anderson, you guys. Got it? I got OHSU.
Yeah.
And still waiting for AZ Arizona and AZ Banner.
Okay.
Come on, you guys. You can do it.
Yeah, we're almost there.
Banner. And I got Mayo, Arizona. You guys are good to go.
Okay, so 3 teams, right? Mayo, Banner, Phoenix, right? And OHSU. You have that, Letitia?
I sure do.
All right.
Looks good.
Okay, here we go. The diagnosis shown by LV and geography. Do I click this reveal response or what do I do? Okay,
How long do we have to answer the question?
During the music. So Dr. Kwan, you would then hit the forward arrow.
Okay, forward arrow here.
And then, and to show the question, and the music will play, and you have the time of the music to answer, and you send your responses again to Dr. Anderson, Letitia, privately. Dr. Kwan, you can start the music at the, if you click
it is playing on my end, so I might have to just sing it with you.
Go for it. I think
10 more seconds. Sorry, I can't sing. Okay, that's it.
Okay, we got everything. So tell me, Dr. Lee, how I should go.
Do you want to call out the answers by each group?
You bet. So
Mayo first, team 1.
Mayo first. Okay, Mayo says Gerbaud. What is a Gerbaud defect?
No.
Okay. And I have, I actually, OHSU, I got you. And what about Banner?
Phoenix.
Did you guys respond?
We never heard any music.
Yeah, we didn't know the time.
I didn't know. Yeah, we didn't.
No. Well, Phoenix,
That's okay.
Yeah.
Send us your response.
Yeah, please do. Yeah.
Just send it right now.
Send it right now. Send it right now. Send it right now.
Go to VSD. It's not a VSD. It's going into.
Send a response now. Yeah, we gotta work this one out, Nkechi. It doesn't consistently play the music, even though it's playing.
Yeah.
Yeah.
And I guess you guys could probably just say it. I mean, we can, if you want to just say it out loud.
Yeah, say it now, please.
They
You
just
give me-
sent it. Arizona Banner, I got you.
Okay, what does Arizona Banner say?
Arizona Banner says, what is a fistula?
No, not specific enough.
Okay.
OHSU?
And OHSU said, what is a VSD, ventricular septal defect?
Yes, that's correct. Yep.
Nice.
Yeah, OHSU.
So,
The
can I
Gervodi
tell
is
you
a
how
good a good try, but you know, in this view, the Gervodi would have to go from LV to right atrium, right, before it comes out. I don't think you can definitely say that it goes to the right atrium. If there's any right atrial filling, it's probably just true tricuspid regurgitation more than it is. It's primarily, in the LAO projection here with the left ventricle, it's just coming across like here in this position, which is definitely not right atrial position. And timing as well as to when the right atrial also pacifies, it's later, right? In a Gervodi, it would have gone faster across and then this way up. Good try, but it's just a ventricular septal defect. Okay, Letitia, you want to call out the scores?
Math here, right? I'm doing some math here with my pencil. So we'll start with Arizona Banner. You guys correct me if I'm wrong, but you bet 600. You bet everything, and you did not get it right. So you're down to 0. Okay. Good try. And AZ Mayo, you guys bet 400, and not right, but you started out with 2,300, so you're down to 1,900. Okay. And last but not least, the correct answer came from OHSU. You guys bet 700. And if my math is correct, you started with 1,700, so you got 2,400. Does that sound right?
Yes. Yes.
So those are my scores.
All right. Thank you, Letitia. That was phenomenal. So let's summarize here. So the winners of this round are OHSU. Yay.
Well, everyone did very nicely. So
everyone did really well.
You really did. I mean, I loved the way everyone played. That was good. Utah, you get an automatic spot, so you'll be going to ACC 21. We will send your names to Kristen West. Oregon OHSU, you've won your chapter competition, so you will also be going to ACC 21. We'll send your name as well. New Mexico, congrats. We will send your name to ACC 21 organizers. For Arizona, the Mayo Clinic, Arizona won their chapter. So Arizona Mayo Clinic, we will be sending your team names to ACC 21 Jeopardy organizers. Remember, it's going to be virtual for ACC 21. And so this was hopefully a good practice for all of you as a warm up to ACC 21 virtual Jeopardy. Thank you, everyone.
And I just want to say congratulations to everybody. Thank you for participating. This has been a remarkably hard year. Hopefully everyone is vaccinated. Is anybody not vaccinated out there yet? Yeah, everybody's back. I just got my second vaccine, which is probably why I'm so forgetful an hour ago. I really enjoyed hearing all your stories and, listening to, hearing about exactly how special all of you are. Thank you for participating, and thank you, Nkechi, for everything that you do for us. Thank you, Liana, for everything that you do for us. Thank you, Letitia, and thank you, Brian, and thank you, Miriam. Is Miriam on?
She had to leave, but yeah, she was on. She just left.
Well, hopefully this is recorded. Thank you, Miriam.
It is recorded. We will be sending it to all the program directors as well to have a recording. So thank you, everyone.
All right, good. Bye.
Thank you, everybody. Have a great one.
Thank you.
See ya. Thank you.
Thank you. Yeah, I'm gonna call tomorrow.